Welcome to Montgomery Heart Wellness, and we just finished clinic today, and I'm meeting with my team, and we want to discuss a couple of patients that had some complex issues that we've been dealing with over several weeks. Guys, who do we have first?
Yeah, I can go first. I'm presenting Mr. Cayenne, 75 years old man, gentleman, with a medical history of significant type 2 diabetes, hyperlipidemia, hypertension, and peripheral artery disease, and atherosclerotic heart disease. His condition was initially diagnosed following a cardiac catheterization done December 2023, revealed severe coronary artery stenosis, and as a result of this, he underwent coronary artery bypass surgery in February 2024. Patient mentioned that post-operative, he had an episode of atrial fibrillation, and he subsequently placed on multiple medication for everything: diabetes, atrial fibrillation, hyperlipidemia, and hypertension. The primary reason for his visit is that he's experiencing chest pain and palpitations, even after the bypass.
The chest pain he's experiencing now, is it the same as the chest pain he had prior to surgery? Or is it worse? Do you know, does he give any ideas?
So he's still having like similar chest pain, but not like the same intensity as before. But he has been told that the chest pain probably due to other blocked arteries.
So he's having pain, it's just not as bad. So there's some improvement?
Yes.
Okay.
So the main thing that he wants to improve his arterial health and to prevent further complication or heart issues. The initial labs or test we did here revealed high cholesterol levels and some inflammatory markers, which is consistent with arterial blockages.
Interesting. So let's stop there. So this patient, 75-year-old man with diabetes, known heart disease, underwent bypass surgery approximately a year ago, and his symptoms may be a little better, but not really. In fact, he may require a new problem since surgery. The atrial fibrillation may be a new problem. Certainly, it's post-operative fib. We don't know if he had atrial fibrillation prior. Maybe he had mild AFib that wasn't severe, but maybe it's just a new problem. But you have a situation where a patient starts with a complex problem: diabetes, inflammatory disease, atherosclerosis. There are probably other issues too, but the bypass surgery addressed the atherosclerosis to a certain extent. But it's only a mechanical treatment. But despite that, this patient, after surgery, is still having these symptoms, still having atrial fibrillation. His cholesterol is still elevated, and his condition probably isn't significantly better. And the reason I want to highlight those things is because we often take a surgical procedure or a particular medication or set of medications as a cure. But what I want to emphasize, even though these things can be helpful, they're really maybe adjuncts or perhaps maybe temporary treatments that should be used only as an adjunct to the patient's overall care.
Yeah.
Sometimes you can do without it. But here's a situation where someone has diabetes, atherosclerotic coronary disease. Despite having bypass surgery, you still have coronary disease that probably couldn't be fixed by bypass surgery. So the probably really wasn't fully addressed, if it was addressed at all. That was my take on it. So cholesterol is elevated, increased inflammation. Anything on vital signs that was problematic or?
Nothing significant. The blood pressure is like controlled with medication, as he mentioned. His hemoglobin A1C was controlled also, it's like 5.7, but the patient still have like the complication from long-standing diabetes, like neuropathy.
So you're still having symptoms of neuropathy. How many medications was he on?
He is like on 2 medication for the diabetes, 2 medication for the blood pressure, and other metoprolol for the atrial fibrillation.
We did a heart monitor. He didn't have any AFib, but it was like more of a post-op AFib. So he actually didn't present to us on Eliquiz, just on like antiplatelet therapy.
Gotcha.
Before he came to our clinic, he had gone to the ER after the bypass for another angina episode.
Okay.
And they told him, you still have other lesions that are moderate to severe. And they said there was still some inflammation even in the bypass graft. So he kind of wanted to know what else could he do to improve circulation everywhere in his body.
Yes, and even the inflammatory markers that we did slightly highlight the NT-proBNP, which is a marker. Usually it's elevated in the coronary artery disease. The other marker or enzyme is the LPPLA2, which is an enzyme associated with the vascular inflammation. So both of them were elevated, like reflecting that this patient still have vascular disease.
Yes.
Inflammatory.
So I would say this patient's coronary disease really wasn't treated. What would you say? I mean, he had bypass surgery, but I mean, he still has angina. He still have, active coronary disease with the symptoms and inflammation. So he had, or certainly not complete treatment of the atherosclerosis. I would argue it wasn't effectively treated. Maybe he bypassed a few vessels, he improved for a little bit, but this is inadequately treated atherosclerosis. What dietary regimen did his other team have along?
He didn't mention any dietary, so the risk factor is still there.
Yes.
Diabetes, the high blood pressure.
So he was still on a standard American diet?
Yes.
Okay, so no nutritional recommendations or anything like that. Okay. So have we started treatment on him yet, or where are we with our treatment?
Yes, he was seen by several of our colleagues here. And so they started him on the meal plan, the detox. So he's done 2 weeks of that. And then I saw him after that. And so the chest tightness, he was having that 3 times a week with exertion relieved with rest. That's gone now. I stopped his glipizide, which is a diabetes medication, so that we would prevent hypoglycemia. And then stopped one of his blood pressure medications, hydrochlorothiazide, because his blood pressure was doing well and he, didn't have any edema or anything like that. And then I also recommended a few other things like the infrared sauna therapy, which helps improve nitric oxide production, improve circulation and vasodilation of your blood vessels. And then also recommended the IV plaque X infusions. Because some studies show that helped reduce the plaque buildup in the coronary arteries. I explained the cornerstone is the diet, so that's why it's great he already got started on that. And so he does live out of state, so he's kind of coming back and forth a little bit. So part of the thing we'll have to work on is really being consistent and having follow-up with his condition, because he also has quite severe lower extremity disease too, even though that's not the main symptom problem.
Is he able to come and spend some extended time with us?
Well, he's been here 2 weeks. He's gonna have to go back home for a week and figure some things out with a family and personal issues. He likes coming here, and when I mentioned how much other things we could add, he's going to try to work a way to come and stay more consistently for a longer period of time.
Yeah, at least 4 weeks to get ECP therapy as well.
Right.
Of all confusions aside. And the treatments we're talking about, starting with the nutrition, is where we're treating the body systemically. The nutrition, as Camille says, is the cornerstone because it's an anti-inflammatory regimen. Now we have different nutritional regimens for different patients, different conditions. These like a raw detox, anti-inflammatory regimen. We make adjustments in this based on the patient individual needs. And this decreased the inflammation in all likelihood. It probably decreased the coronary spasm. That's likely why the angina subsided. The diabetes, of course, our studies show during this nutritional regimen, hemoglobin A1C comes down, diabetes better controlled. We also know that with improved nitric oxide production from the nutrition, the leafy greens, that can also help the blood pressure go down. She's able to decrease the medications. So the issue of polypharmacy becomes less of an issue. And so this is how you treat someone like this with not only coronary disease, but he has, inflammatory disease, he has diabetes, diabetic neuropathy. And this approach is one where a patient like this should start at this regimen. And had I seen it initially, I would start this approach prior to taking them to surgery. I'm not saying you wouldn't have had to go to surgery. I'm saying you want to start with this approach. Why? All right, start this approach first. Let's say he absolutely needed surgery, okay? At least he had a repmain or something where he needed surgery. I would still start with this approach first because the nutrition decreases inflammation. Decreased inflammation will help improve the surgical outcome. Because when you make a surgical incision, you're increasing inflammatory markers. Okay, that's a vulnerable plaque in the artery could, ulcerate. You have a heart attack on the table. That's very reported. It's not unheard of. Post-op atrial fibrillation is likely due to the increased inflammation from surgery. So post-op AFib, I think, is probably triggered by inflammation because they use drugs like colchicine to help suppress it with anti-inflammatory properties. But if you go into the surgery with an anti-inflammatory nutritional regimen, you likely decrease the risk of that. So a 2-week intervention like this prior to surgery, even if you need surgery, I would say would have been beneficial. And let's say, for instance, hey, tried this for 2 weeks and got much better, you could continue indefinitely to determine whether or not you needed surgery. So it's this type of approach we like to take, unless surgery is an absolute emergency or angioplasty an emergency if someone's at the throes of a heart attack. Most surgeons don't operate someone who's at the throes of a heart attack anyway, but they need emergency standard therapy. That's another issue. So it's a great clinical case because it shows how this broad approach is really the definitive approach, and you can really see this approach compared to surgery, how the patient overall got better. The surgery didn't get better, improve his diabetes, but the nutritional intervention did. The surgery didn't improve his coronary disease or symptoms, but the nutritional intervention did. The surgery did not improve his blood pressure, but the nutritional intervention did. And in all likelihood, over time, the nutritional intervention will likely help the peripheral neuropathy side as well as prophylaxis disease. The surgery won't do that either. Any other thoughts, comments?
I mean, I agree. I think the nutritional aspect, it improves circulation everywhere. Surgery is targeted, maybe bypass a native blockage, but in this patient, it didn't alleviate his symptoms of coronary artery disease completely, and that's why he came here, because he recognized that too, which was good.
Yeah.
Also, maybe because they approach the high blood pressure, diabetes, and the high cholesterol only with medication. And right now, the medication itself, it has like side effects and everything. So right now, when we start the diet or the nutrition might help decreases, like, as you mentioned, the polypharmacy, so it can improve the quality of life.
That's right. And that's the key point. The quality of life is very important because if he's taking for your medication for your side effects, he's going to feel better. And these lifestyle changes can be easily integrated. I mean, people can change their lifestyle. You can change how you eat, the way you eat, recipes. It may take time, but this is an easier thing to integrate than have to take medication that are making you feel bad all the time. If you're feeling better, it gives you more incentive to make these integrative changes. Who we have next?
So the next patient, Miss J, she's an 85-year-old female. She has history of atrial fibrillation, ventricular tachycardia, defibrillator, heart failure, COPD or chronic obstructive pulmonary disease, secondary to chronic lung infection and some multiple PEs or blood clots in the lungs. She's had a lot go on and a lot of inflammation with her heart and lungs over time, and she's on portable oxygen. She had come to our clinic after not being here for 3 months, and she had reported more fluctuations in her heart rate that she was noticing, and sometimes more dips in the blood pressure. She would have more episodes of weakness and dizziness. No fever, chill, no pain with urination, no increased sinus problems, actually. But, when I saw her today, I was like, we need to recheck pretty much everything. We need to check her thyroid, make sure she's not anemic, recheck the pumping and structure of her heart, and check if she's going back into more arrhythmias. One thing from her history, that she was put on a new inhaler for her lung disease, a new type of inhaler that combined 2 medications, and those medications can trigger more arrhythmias. So that was one thing.
How long ago was the new inhaler started?
A few weeks ago.
Okay.
So it was Anora, which is a combination of anticholinergic and a beta-2 agonist. So they can increase atrial fibrillation or tachycardias. And so on our EKG today, it was more irregular, more like a multifocal type of arrhythmia, not true atrial fibrillation. But I told her, let's put an external monitor, take a deeper dive, and did very comprehensive blood work. And then wanted to talk to you about her new inhaler for her COPD, because she is dependent on oxygen, and wanted to see what your thoughts were about getting off that inhaler, talking to her lung doctor. I didn't stop that inhaler yet because I don't know the recent findings of any lung testing, and I wanted to make sure other causative factors of increased arrhythmia weren't at play. Like, she's had a UTI in the past that threw her heart rhythm abnormal again. Wanted to make sure she wasn't anemic, wanted to make sure it wasn't a thyroid problem. She does take a medication to help with arrhythmia called Soltalol, but I have to be very cautious. If I increase it, it could lower blood pressure more, and that her blood pressure runs on the low side. So
this interesting patient, or A's, with significant lung disease and heart disease, arrhythmias, and we've been taking care of her for a long time. And, the lung issues are multifactorial. There's some chronic lung disease. I think there's a chronic inflammatory component to it, and we've been addressing that. It's always been my take, if we be very aggressive with the anti-inflammatory component, we can get all this under control. She did well with ozone infusions in the past. She's been reluctant to repeat it for, I guess, different reasons. Also, I think liposomal curcumin has helped. Serrapeptase has helped her before. So we've done well with her with this regimen. Now, my recollection, the last time I saw her, maybe a couple months ago, she was relatively stable. I don't know what prompted the need for the new inhaler. Did she have more symptoms or hospitalizations or exacerbations or what?
More weakness, shortness of breath, not another hospitalization. The other thing was she was on high dose of some anti-inflammatories like curcumin, serrapeptase, and like a sinus rinse with the liquid advantage, kind of an anti-pathogen natural supplement.
I remember we started that. Now, she was having some sinus congestion. She said that had improved.
That improved, and that's still improved. So she doesn't use the nasal wash as much, but with her 3 anti-inflammatory supplements, on 2 of them she went down on the dose some, just on her own, for just reasons of obtaining it, right? So that could be a factor. If she went down on her anti-inflammatory supplements, could that have triggered the need for another medication from her lung doctor? You know what I mean? But that could be it. So I told her to go back up on the higher doses, but still wanted to check other causes too, at her age,
And did she notice symptoms of palpitations since being on the inhaler? How did she feel before and after the inhaler?
The most of her problems were after the inhaler. So
They are what?
the more the weakness, the palpitations, and
Shortness of breath?
the shortness of breath, that was a little before and after.
She's basically remained short of breath and picked up 2 more symptoms.
Correct, because we put her on our oxygen when she got here.
So based on that assessment, what should we do with the inhaler?
Probably put a hold on it
Yes.
because I think
It's not making it better.
causing
It trigger other like
right
It's making it worse.
and
And plus you have an arrhythmia.
like,
Now the arrhythmia could also make her what?
more shorter breath,
Yeah, and what else? More
more
pop.
weakness and tired. Yeah.
So here's a situation where you have a patient with heart disease. Now, let's talk about the heart for a minute. Heart's a pump, as you know. It has to work efficiently. It contracts, relaxes, contracts, relaxes. Blood circulate from upper chamber to the lower chamber, and then out of the heart from the left side goes to the body, from the right side goes to the lungs. The efficiency of the pumping of the heart is important for the efficiency of the circulation of oxygenated blood to the body. If the heart doesn't pump efficiently, it doesn't circulate blood efficiently, it doesn't circulate oxygen efficiently. If the heart doesn't circulate oxygen efficiently, then you can become more short of breath, you become more fatigued, okay? You have chest pain, you have lots of symptoms due to poor efficiency in the circulating blood. So she was more fatigued, shortness of breath did not get better,
Right.
and then she had new onset palpitations.
Correct.
So the palpitation are likely related to abnormal heart rhythm, the atrial arrhythmia. So what a abnormal heart rhythm does to the heart, it makes the heart beat less efficiently. When the heart's contracting in order and rhythm, it beats efficiently. When things are out of order, it beats less efficiently. When it beats less efficiently, there's certainly blood less efficient, oxygen goes to body less efficiently. That makes you tired. So what the inhaler did, which is supposed to treat the shortness of breath, it didn't really do anything for the shortness of breath of significance. But what it did give her a side effect of an atrial arrhythmia. The atrial arrhythmia caused the heart to beat less efficiently. When the heart was beating less efficiently, it circulated blood less efficiently. When it circulated blood less efficiently, she became more tired. And because of arrhythmia, she felt it because the heart was beating and she felt palpitations.
Right.
So the medication brought on problems. It did not resolve problems. And the reason shortness of breath may have persisted or progressed may have been the fact she decreased the anti-inflammatory supplements. Our favorite increase anti-inflammatory supplements. Maybe there are some other things we can do. Some people do hydrogen peroxide inhalers in case there's like a lung infection. So that can help out and other things like that. But I wouldn't add an inhaler to someone with arrhythmia like this. We'll tell the patient to stop the inhaler.
Correct.
So again, another situation where you have to look at the total patient, you have to look at the medication interacting with the patient, and you have to look at other side effects. And the symptoms of fatigue gets to, well, why is she fatigued? You have to look at disease mechanism. And so if the heart's not beating efficiently, she could have chest pain. Okay, that could be a symptom related to the same thing I just said.
Right.
Okay,
Yeah.
so that's why I would say that I would hold the inhaler, give her 2 more weeks. If she's better, then we know something. But I think we know something now. I hope that was helpful to you. The two situations of very complex patients with complex set of medical problems. But what I want to emphasize is that these conditions aren't as complex as they may seem on the surface. I mean, they are complex in one way. But another way, if you step back and look at the fundamentals of how the body works and how the body responds to nutrition, medications, or the like, this can help you address these problems in a more straightforward manner. So, I hope that was helpful. If you have any questions or comments, leave them in the comment section. And until next time, take care. Thanks for watching. If you got value out of this video, please like it, subscribe, and hit the notification button to see our next show.